Hey everyone, so welcome to XPC Talks. We're very excited to hear from Ben about his experiences living in a community, senior community, and what it was like. And so, Ben, we'll pass it off to you. Tell us a bit about yourself, what got you interested in this, and then, things that you saw.
Yeah,
And
thanks
then,
so much.
yeah, and as a reminder, y'all can ask questions in the chat, or, feel free to raise your hand or interrupt Ben. We'll keep this conversational.
Yes. Cool. Well, thanks, Paulius. And thanks so much for you inviting me to chat today. And thanks everyone for joining. The XPC community is amazing. So I feel really grateful to be a part of it. And I feel really grateful that there's so many good people doing good work within it. So in today's chat, I'm going to talk about a few different things. I'm going to talk about my takeaways as an entrepreneur living in a care community. I'm going to talk about 3 problem areas that maybe you can and should work on if you're focused on care communities or older adults. And I'm also going to share some things I learned, some wisdom about aging confidently. And then we'll have time for Q&A. But like Polly said, feel free to interrupt if there's any questions you have. And I also want to, reiterate that this is a conversation. So feel free to share your reflections, your stories, your interpretations. I'm really interested. So just to start, a little bit about me. I'm Ben. I live in New York City. I'm from Massachusetts originally. Before going on my entrepreneurial journey, I worked at Amazon. I worked on the shopping website, helping customers find the right products at the right time. That had to do with a lot of data and engineering behind the scenes. And before working at Amazon, I worked at a startup with doing medical record interoperability called One Record. That company was acquired by Milliman a few years ago. And we've really seen the interoperability space change and progress, and I'm very excited about it. And I was really excited to be working in that space. That's what got me into health tech, what really got me paying attention to healthcare, and it was a great experience with a great team. Before that, I worked in a myriad of other startups, from insurance tech to voice tech and NLP, before ChatGPT sort of revolutionized that. And currently I sit on the Weill Cornell Technology and Thought Leadership team. So helping physicians there and physicians around the country think about different new technology and how it can be used in care settings. And then I think very importantly to me is I try to spend as much time as I can volunteering. I'm an active hospice volunteer with a few different hospice agencies in New York City, one of them being VNS Health. And I also participate and volunteer at my local senior center just down the street from my apartment. And then I also like to add the human side to the work side. So I am also a family member and a friend to many. Here's a picture of me, my parents, and my brother in Brooklyn. And then this is also a picture of my grandparents. This picture was taken quite a long time ago, but my living grandparent is my Nana, who's in blue, and she's 104 years old now. Okay, so now what you came here for is to hear about my journey as an entrepreneur in residence. I was very privileged to be an entrepreneur in residence with the organization United Church Homes. They operate senior living and care settings across the country, as well as have affordable housing across the country. They had me go to a community in Marietta, Ohio. It's called the Glenwood community. And Marietta, Ohio is right on the Ohio River. It's on the southeast border of Ohio. So right across the river, you see West Virginia. And I really learned a lot about West Virginia, more than I ever knew, because a lot of people grew up there and then moved to Marietta. Marietta is just a beautiful place, a lot of history, a lot of rich history there. And then the picture on the right is the picture of the Glenwood community. This is specifically the Pines, which is the assisted living building. And it was just a remarkable place to be able to live in. And so that's what I did. I was there for 2 weeks. My typical day was going through a morning meeting. So that would either be at senior living. So with the senior living staff, the assisted living staff, or there's a skilled nursing down the street. And each of those morning meetings had a focus on what they were doing. So obviously skilled nursing was different than what's going on in senior living. And then at noon every day, I had lunch with residents at the setting that I was at. And then at 5 p.m., I also had dinner with residents. So my schedule was different than it is in New York City, but it was so much fun to be able to sit down with someone new every single day and learn from them. I was living in a 2-bed, 2-bath in their guest apartment on the second floor of the senior living residence. And so I was living right alongside everyone else. I think the average age was maybe 85. And then I got to bring down that average age, and it was just so much fun. I'll get to the fun part, a lot of the fun later, but let me just jump into the takeaways. And so before I get into that, quick disclaimer is that these are focused on takeaways for an entrepreneur or someone who wants to innovate in the space, but they could be used more broadly too. And then the other thing is, like, this is my experience. So, your experience may vary.
Hey,
okay.
Ben, before you jump into takeaways, could you just walk through what made you want to do this?
Yeah, sure. I mean, first off, I'm deeply committed and motivated to help out older adults. I have had great experience with my own family, but I have a draw towards just helping folks that are older, that sometimes don't get to see young folks as much. And there's just so much life and so much fun and so much wisdom that I really enjoy being around. I have a deep draw towards end of life too. That's why I'm an active hospice volunteer, and that's also given me a lot of good perspective on what I want to go forward doing. It's just a remarkable experience to have, and so when it was offered to me to go spend 2 weeks, I jumped at it, and I'm really glad I did. And I hope more people can. Whether that means going down to your local senior center or spending time at, the local town hall or wherever people might gather where you live. I think people should spend more time with cross-generational folks. So that could mean, people who are older adults, but it also could mean just a different generation than your own. So that's a bit why I wanted to do it. Thanks. Takeaway number 1 is the show will go on until it doesn't. So, something I learned was that founders often think that the problems they identify are the most pressing. And that means that, suddenly you have this great idea, or you've stumbled across this challenge and you go, oh my gosh, this is the nucleus. This is going to be what can change healthcare across the United States. And that is just, respectfully not the case, because being on the ground, you see that problems exist and the problem you identified exists, but the hospitality and care is still going to be delivered. And I saw this in a few different places. There's, simple things like digital systems. Example, a digital system not being in the kitchen. That means that, orders were coming through different, just sheets of paper. The inventory wasn't really tracked in any way that wasn't on a spreadsheet or anything, but food was still being made and people were still eating. If someone falls, a protocol was going to be followed. People were going to be able to continue on, receive the care that they needed, but still everyone's day-to-day was going to move forward. And then things like when the census is low. When the census is low, that's tricky. It puts organizational pressure on, but adjustments will be made. And again, hospitality and care will still be delivered. So over time, yes, these problems erode service, but the pain is really only felt by who knows about that erosion. Otherwise, everyone there is still continued on that mission of delivering hospitality and care. And, the takeaway is that, yes, maybe your solution was needed yesterday, but unless, business is being, stopping full stop, which doesn't really happen, then care is going to continue on. And we need to take into account, that resilience and just how those day-to-days go. Takeaway number 2 is there are even more outside forces that play into care and hospitality. So everyone on this call is likely understands, and I'm certain they do, and you do, that there are multiple stakeholders and many incentives in US healthcare. But being on the ground, I was keenly aware of more and more outside forces and that play a part into what happens in an organization. And these are a lot of what happens at the macro level of society, at least in the United States. And so something I heard over and over was how, or learned, was how the housing market plays a part into senior living and assisted living. People on tours would say, I'll move in when my house sells or when my condo sells. And these are people who are willing to move into a place that, is a new place. They probably didn't expect to move in there. They're ready, but they cannot move in until they have finished selling their home. And right now, at least for some folks, their houses aren't selling. And then when their houses don't sell and people don't move into senior living, it puts a lot of pressure on the organization because they have a lot of vacancy. And so that's something that you just don't understand until you're looking a little broader at the picture. Same things I learned about public health regionality and seasonality. People are being frugal, more than you might expect. People may be taking half a pill or having their medication every other day because they just are afraid to spend money on medication or they want to be frugal. Regionality, from the outside looking in, you say, oh, every care setting is the same. They all need my help with XYZ. Well, if there's just one care setting in an area, maybe it's overwhelmed. Maybe the hospital just sends everyone there. Or if there are many care settings in the area, maybe it's underwhelmed. Maybe there's a lot of choice and you just need to see that as a broader picture. Then finally, seasonality. I was there just last month and their census was lower. I asked around, what that case would be. Outside of different things, the levers and pulls that you can do as an organization, they were talking about it's summer. Census is lower because there's fewer elective surgeries. People are healthier because they're not in enclosed areas. So these are different things that, you might not see until you're on the ground.
Ben, I have a question about the seasonality.
Sure.
When you talk about that, you're talking about non-permanent residents, like people who are living there for part-time, or are you talking about just fewer people tend to move in at that time because they don't need to yet?
Thank you. That's a good clarification. This is specifically for skilled nursing. So for people who are coming into skilled nursing or being referred to skilled nursing. Thank you. And then the last takeaway is one size does not fit all. So obviously I have my prior experience and I have my family experience, but that doesn't mean that it translates one-to-one with what happens in the community that I lived at or what will happen at a different one. Each organization has its own way of doing things. Each resident, each patient, each participant, however you want to say, has their own life and has their own experience. And people react differently to different things. So I'll give you an example of some people wanting to stay on care and some people wanting to leave care. I was at the skilled nursing home and they received a fax from a resident's MA plan. And that plan was basically saying that this person has progressed enough, they have recovered enough, they are no longer going to receive their benefits to be in the skilled nursing, and they should be discharged on a Monday. And so the social worker and I walked down to see if that person wanted to appeal that decision and maybe send some information forward to say that they wanted to stay longer. And when we walked in and we gave this person news, they started crying, and they were crying tears of happiness. They were so happy to know that they were going to be discharged because they wanted to go. They wanted to see their 2 dogs at home, and they were ready. And that was a beautiful thing. But that experience isn't for everyone, because then there's other people who want to make an appeal, who want to stay longer, who want to receive more care or get a little bit stronger. And so as an outsider looking in, you don't realize that, you might forget that there's different dynamics at play. And maybe it's not people wanting to move faster, move slower. Maybe these organizations have different incentives. Maybe the organization wants them to stay a little bit longer. Maybe the MA plan wants them to move a little quicker. So things aren't all one size fits all. And it just really underscores about listening and understanding, and then also giving people space to show and tell you how they're doing things or how they're receiving things. So now I'll move into the next section, which is challenges to solve. I'll keep it a bit brief because I think some pieces will be obvious. So these are the big three problems in post-acute settings in SNF and ALF. The three are staffing, compliance, and census. And census could also be a term for revenue, but I'll just keep it as census right now. Staffing and hiring, obviously a huge problem across healthcare, a huge problem or challenge across a lot of markets in the United States. And it's interesting for post-acute settings because from what I've heard, they cannot, and what I've seen, they can't pay as much as the hospital down the street. And maybe there are people who want to work in a skilled nursing or an assisted living, and maybe they don't. But they're also competing with McDonald's or they're competing with the grocery store down the street. And so staffing is challenging because you have those other market factors. Compliance is huge in post-acute because so much is Medicare and so much is Medicaid. And so there's just a lot of paperwork and bureaucracy that's needed to deliver care. And it can really burn out an organization. It can really burn out, select roles. And there's a need to be able to smooth it out and to be able to consolidate it because, maybe you have compliance in one area, all set, but the compliance in another, not so much. Census is basically keeping the lights on. The challenge there is for two reasons. One is you need to have revenue, but two is like your organization is set up to work at a certain census threshold. And when it's below, you really have to make adjustments. And those adjustments then land on your staffing, like nurses not being getting hours because they just don't need as much staff. And then those nurses, might be upset that they don't have steady hours, and then they might go somewhere else, and that affects staffing. So census is a crucial area. And now the one that I really want to talk to is being in care settings just reminds you how much people being healthy and living a healthy life is important and is the challenge to solve. I think we forget so much, especially in health tech, that it's about people being happy, healthy, living their best lives, doing that. And we try to solve for these computer administration problems. And, a lot of that does lead to better care and, people being healthy. But gosh, to go and just say, I can help with infection control. I can reduce falls. I can, reduce or smooth out readmissions, health literacy, social services. These things are just so important. And when you're in a care setting, you are reminded every single moment that is the important job to be done. So now I'm going to transition into...
Can I ask you a question about that?
Yes.
So that totally makes sense from a lived experience, being on the ground and having conversations, obviously, with the residents and seeing how it goes. As you had, I'm presuming you also had lots of conversations with the administrators.
Yes.
The way the slide is laid out is kind of like, here are the three big problems, and then a bonus is this thing. Is that how they look at it? Like, said another way, what's the way the slide is laid out is different than kind of the talk track you just gave. Like, if you came in and said, look, my core focus is going to be reducing readmission or reducing fall rates, would the administrators, or oftentimes the gatekeepers to being able to get services into these facilities, be as excited as if you said, I'm actually going to solve your census problem or your compliance problem?
Yes, they would. They would if you could actually do it. And I think people are burnt because they've heard that people can do it and then it doesn't work. Or there's like these challenges to doing some things and they make sense. But I'll give you an example. Like falls, there can be, for falls, you see different sensors, and there's all sorts. There's either cameras or non-camera kind of, viewing sensors. But there's also things like pressure pads. So if someone gets up out of their bed, maybe an alarm or alert would go off. In some places, depending on how that is executed, it can be considered a restraint because you're restraining the person from getting up out of their bed. And so the administrator has to look at this and really understand what, state they're living in, what, rules or regs are happening, and know whether or not it's going to actually reduce falls or if it's going to be effective. Now, when you talk to an administrator, to be frank, they want to deliver the best care, and the best administrators do, but they also know that they have to keep the lights on so that they can continue delivering care. So a lot of things happen at top or bottom line, which matters for census. Compliance is a huge one because that can just turn off everything all at once. And then staffing, again, you need certain staffing levels. So those three are really the big ones for administrator, but they too want to deliver the best care. And I think, if you're delivering good care, then the other three come naturally. Staffing and hiring is much easier at a place that is running smoothly, right? Compliance is much easier when you don't have a ton of, falls or investigations or whatever it is, low quality scores. And then census is sort of natural if you're doing good work and the community knows that. So I know it's a little bit of a roundabout answer, but it is, I think the administrators want to be thinking about it, but, we live in a world of ROI, and that's important. So it is a balance of what matters.
And then Ben, there was one more question in the chat, and Shantanu, if
hey Ben, thanks for sharing. Just a question about like external family management. How much is administration or caregivers having to like document things, talk about what they're doing, or is it just kind of like you're here now? And trust, put all our trust in them. So how much of this is like collaboration on the treatment plan and like what they should be doing?
Yeah, that's a great question. So in a post-acute setting, like skilled nursing or assisted living, everything is documented. All of the care that's delivered is documented. And that's a big thing. But then at skilled nursing, is specifically, any change in the care plan, any refusal of food or anything out of the norm is shared with the family members. And the family members it's again varying, right? Some people are very active. They have very active family members. Some family members aren't as active or won't pick up the phone. But it is the responsibility of that care setting to alert the representative of what's going on with the care plan. And at least in the community that I was a part of, when people were active, they were active and friendly. When someone was on the way towards end of life, they were receptive to the hospice conversation. When someone wasn't eating, they were receptive to talking about, giving the chef or the cook different ideas about what that person would want to eat. And so that was really nice to see. So there's, I think, a lot of communication, but it really starts with the family and making sure that, they are involved or that you have the right person, because that's another thing, this is something I've heard outside of, my 2 weeks there, is that, different siblings have different perspectives. Say mom and dad have 2 children, one child lives nearby, one child lives across the country. Those 2 folks have different perspectives on how mom and dad are going to receive care. And, more often than not, the folks that are farther away want to push more care, and the folks that are closer have a more keen understanding of, maybe what mom or dad want.
So let me know. Are these, I guess just as a
Sure.
secondary thought, are these care guys in the middle of that conversation? Did you see themselves fielding a lot of interfamily dynamics, or is it just kind of a one-way broadcast, here's what's going on, and kind of move on?
I think they, at the organization I was at, they fielded them a bit, and they were very open to that. But I know that in some situations they had to step back. So I really can't say whether, that was normal or if that was just, the good heart of the folks that I saw on the ground.
Great. Thank you.
Okay, so now I'll just do my best to impart some wisdom about getting older for you all to take or you all to share with your family or friends. Okay, the first one is it takes courage and it takes community. Moving into a senior living is a courageous thing to do. Showing up to a senior center for the first time, just for a day of activities, is a courageous thing to do, because you're basically walking in to a first day of school and it's your first day of school, but it's not everyone's first day of school. So everybody else might know each other, and you feel like you don't know each other. You don't know them. And that can be a very isolating feeling. And so it is worthwhile to be courageous, and it takes time. It might take some pressure, but if you have that courage, it definitely pays off. And I implore you to be courageous, or to, lend a helping hand to help someone else feel welcome. It also is helped a lot by community to not feel isolated, but then also community, if you're moving in somewhere, to know that, there are friendly faces that, you can reach out to, you can have a meal with. And so where I lived, at the Glenwood community, they have a resident-run program where they help to introduce newcomers to other folks. And they also do a good job of transitioning folks by having them, once they know they're going to move in, by having them maybe stay at the guest residence for a few nights so that they can feel comfortable before they move in, or get to know some folks before they move in. And I think that's really helpful. But community is huge across our lives at this stage, or across our lives in the next part of the next stages. Continued investment in relationships just goes a long way. Number 2 is about agency and asking for help. Obviously, as you get older, you lose a bit of agency, and you don't want to. So some folks are stubborn and just don't want to lose any of that agency. Some folks are relinquish their agency and just, sort of give up. I think that you need to do a balance. You need to really continue to have that agency for yourself, understand how your mind and body are changing, and continue to make every day an adventure and fun and challenging and engaging. I learned so much about, folks who asked for help, received help. And that's from, resident asking for help to another resident for cooking, asking for help from the activities coordinator. There was such great staff on site to help change a light bulb kind of thing, take out the garbage. And, some folks are afraid to ask for that kind of help, but asking helps people stay independent longer, helps maintain community. So I think for yourselves, feel free to ask for help. It's been one of my New Year's resolutions, is to ask for help more. And, for folks around you, you can always ask them how you can help them. And then the last one is that growing older can be fun, and it should be fun. On the left is a picture of everybody playing bingo. Bingo is huge. Bingo is like the biggest thing going at senior living and assisted living. It's so active. And by the way, it's so fast. It's just like before, I-10, like things are just moving quickly, and people are really paying attention to make sure that there's true bingos going on. And on the right is a good friend I made, a woman named Marie, and she is just so vivacious and fun. And, she chose to do it. And she would tell me all the time, it's about your attitude. It's about your choice to have fun, to live your best life. And just a quick story. She invited me to her apartment to help with her printer. And we tried to print, and we tried to send a test page down, and it wasn't really working. And so we let it go. The next day, she saw me in the hallway, and she was like, "Ben, there's a ghost that printed a page overnight. It's amazing." And it was so fun. We went back to our apartment. We sort of figured out the problem going on, but it was just, it's about having fun, having fun with everything going on, being nice to folks. So it makes, being there, it makes me at least excited about getting older and having fun as I get older. So I'll just recap. So the 3 takeaways were that, while you might see urgent problems, care communities are going to continue to adapt and, give hospitality and give care. And, our solutions, or our way of speaking with these organizations, should recognize that. If we can't see a root problem, then maybe we need to look at the broader landscape of things, like on the macro scale, like housing or healthcare economics. And we should always be considering the unique context of each unique organization and each unique resident, listening and understanding and not assuming. And then on the challenges, there's a lot of big, impactful, patient-centered things to work on. And so the question for all of us is, how can we live a happy and purposeful life? And how we can scale that. And then finally, my ask for you, this is my ask, is to remember that getting older can and is fun, and it's your choice. Remember that having community around you is vital, and that it takes two. That means that you need to reach out and can't just expect others to reach out to you, and others shouldn't expect, you to reach out. They should also proactively reach out to you. So do reach out to someone, make a plan, or give them a hello. And then the last one I want to ask you is that you share a lending hand with someone, help them feel welcome, whether you know them well or not, and then also to ask for help when you need it too. And that's it. So I'm happy to take more questions, or also really interested to hear what resonated with you, or if you share similar observations or have different observations and experiences.
Ben, this has been fascinating. Also, really love all the photos. I appreciate you humoring me with my request. I had a question around food. I was curious if you're going to come back to it, but like you said, you had a lot of meals with the residents. What was the food like? And because I'm family medicine trained, and so we did a lot of work in assisted living, facilities and stuff. So I got to try some of the food, and it wasn't the best. But yeah, what was your experience like?
That's a great question. The food at this community was very good. And that is a testament to their chefs. They have at the skilled nursing home, they have this very experienced chef named Ryan. And he was a regional director of this larger senior living community. And he was doing all this stuff. He took a pay cut in half to work at this one. And he wanted to be closer to his family. But what he does is he provides such a great perspective, is that, food is something that gives people so much joy, especially when they're in skilled nursing. And so he has a lot of care in what, he does to share that with them. And he goes out to all of the residents in skilled nursing and asks them what they like or what they don't like, on top of their own, dietary things, whether they need, less salt in their food, or they need, softened foods or something like that. And that's really nice. But I will say that he's also a big believer that food should be food, because I've been in other nursing homes where, you have sort of you have mashed potatoes that are scooped with an ice cream scooper, and then you have pasta that's scooped with an ice cream scooper and things like that. And that was not the case here. And I think that's really something that makes living quality go up, is when you have good food, and that, that's a real stimulus for folks, especially if they're not, if they're in skilled nursing and they're not really leaving their hallway too much.
Totally. I'll keep asking questions unless you guys drop something in the chat or speak up. Have you seen anything interesting where people were like misbehaving, where they're trying to, just, I can keep it open-ended actually.
I don't know what you mean by misbehaving, but it's so interesting, the interdynamics that I didn't realize, because, from an outside looking in, everyone's perfect. All these like older adults are these like perfect humans with wisdom. And it's kind of like, again, like high school or maybe like college, like moving into a dorm, and, people have different dynamics. Some people get along, some people don't get along. And that can be really amplified at a place like the nursing home, where maybe some people also just have general behavior tendencies that are different. And so, in senior living, like by misbehaving, there were things like some folks wanted people to wear a jacket when they're in the dining room having dinner, like a blazer kind of suit jacket. And they would be upset when they saw other residents not doing that. So that was very fun and interesting. And also it shows a generational change. And then, in skilled nursing, there are folks that when they don't like each other, they make it known, and that's something where, the nurses and the CNAs have to come in and make sure that, they understand all that behavioral dynamic and make sure that, there's peace going. So, it was fun to learn all about that stuff and see, it's not all perfect, but, I like to tell the happier parts.
Yeah, that's great. Okay, Rob, you have a question.
Yeah, so I really liked the analogy that you made of the first day of school, like that residents who are moving in are on their first day, but no one else is. What is your experience with what these communities do for people who are moving in to make them feel more welcome versus like how much it's on the new residents themselves to try to like build that community, as you said?
It's really interesting. It is a lot on the resident. It's kind of remarkable that this community has a resident run sort of transition or like onboarding kind of program where someone leads, helping to introduce folks to other folks, making sure that, someone's checking in on them, that they feel welcome. But, I heard, especially from the men at the senior living, that it took them almost a year to feel at home in senior living, even though they knew it was the right place, for them to reside, that it just took them a long time to actually like feel that this was a place that they had community, or that they, gave up, maybe taking care of their property. That's something I heard a lot from the men, that, that this was right, but they did get around to it. I think that what these communities can do is to recognize that those transitions are hard. And I think they do, but they've been operating so many years, like, it's hard to see the forest through the trees kind of thing. But they're have activities coordinator, and when you're just or for me, someone like me, when I'm a friendly stranger coming in, people are very open. They're saying, this one woman, she wanted to go on an activity that I went on. We went down to this place called The Jug. It's like a Dairy Queen, so it's like an ice cream / snack shack kind of place. And I was eating with her later, and she was like, I wanted to go on that activity, but I was sort of bashful. Like, I didn't feel like I knew what was going on. Like, and I was like, oh, that's really interesting. But then, if you share that with someone, they're really interested to be like, oh no, you should come next time. Like the activities coordinator who works there, an employee, they're going to more proactively reach out and be like, hey, we would love to have you. And I think, that goes back to me saying like, you can ask for help, or if you're more vulnerable and you share things, like, I think people are willing to be welcoming.
Interesting.
But I think if there's more programs in place, like outside of like, my 2 weeks at this senior living, at a senior center, like I would love to see my local senior center have like an onboarding day. And I would love to see them do it like monthly, where like, it was a bunch of new people, everybody getting to know you or having getting to know you activities. Cause it's really difficult to walk in, and it's like going back to the school analogy. It's like seeing like the cool girls table or the cool boys table, and you're like intimidated, and you're sitting there and you're like, should I go up to them? Should I not? Do they like me? What's going on? Should I come back tomorrow? And so it takes time, and it really is helpful, just like it is like in school or like with family functions. At least for me, like going to a family function with my brother is a lot less intimidating than going by myself. And so like if you can go to some of these things with someone else, I think it is a lot less pressure.
I'm also super curious, how are you going to solve this whole thing, like, because you didn't really share too much about what you're working on. I mean, this is a good space, I think, to brainstorm if you're at a place where you want to, talk broadly about it. And, it's kind of like, this is somewhat, like, I guess I'm somewhat surprised how many people showed up, because I mean this is like a pretty niche topic, and not like the most flashiest of things. Like we're not talking like deep AI like benchmarks or whatever. So like everyone's probably thinking something related to the space. So I think if you can pick the brain of people who are here, that like go for it. If anyone else also wants to share at the end like how they're thinking about approaching this senior aging space, we can make time for that too. We have 10 more minutes or so. So Ben, why don't you share what you're thinking and stuff?
Yeah, definitely. So I am really interested to hear how other people are thinking about approaching the space and what you're working on. I came into this space thinking a lot about end of life and goals of care and advanced care planning, I've started to look more broadly because I've learned more about these other care settings, and I'm sort of taking on my journey. And then I started to match this with my skill set of working in startups with data and trying to use that data in meaningful ways. Coming out of my experience living for 2 weeks in Ohio at a senior living community, I really got the bug to work back on those big care problems again, which is, helping people live happier, healthier lives. And so what I'm thinking about is still using some data and, trying to use the data that is available, whether it's through the EHR, whether it's through some of their other, software vendors, to be able to help identify, if someone needs help earlier, to help identify when someone might, need a specialist to come in or might need another perspective from another clinician, or even, when a clinician may need support as well. And so that's what I'm thinking about. I'm just, to be more specific, I've started to look into like a lot of medication management. I've started to look at, what happens with infection control and also fall risks based on clinical documentation. And so these things have become really forefront to me. And I also think there's like a lot of gaps there too, is like when I see data, because data is only documented the way it's supposed to be documented. And so I'm also curious to see, if there's other indications from these other softwares that are out there about, how that can help paint a picture, add more dimensions to help these care settings know more about their patients, improve their quality, and improve their delivery of care in like a smoother way. So that's sort of what I'm thinking about. Still early broad days, but I'm really motivated by what I saw.
Yeah, thanks for sharing that. Matt, I know you're in the space. I'd love to, if you have a reaction to Ben's stuff, great. If not, you can also, share how you're thinking about stuff.
Yeah. No, thanks for sharing. I thought, what a great way to live in the problems, and the joy, right? So it's really inspiring. So thanks for sharing your story, Ben. So I think the way that I've been approaching, which overlaps, which is why I'm starting there with the way that you're thinking about it, Ben, is we've been spending a lot of time on care delivery, but much more focused on third-party providers. So in most of these ALFs and SNFs, there are rounding physician groups, usually heavily staffed by NPs, PAs. I'm curious if you had any interactions with those folks during your time and what the perspective on the ground of those types of folks were for both residents and administrators. But, there is like a massive staffing crisis, to your point, in SNFs. And so as we started talking to folks in the space about improving quality of care, almost invariably everyone directed towards these provider groups, who are oftentimes actually more consistent forms of care than the folks actually working inside the skilled nursing facilities. And so that's the angle we've been taking. We've been spending a lot of time with the third-party provider groups.
Yeah, excuse me. That is definitely something that I saw and experienced. It was really interesting in the skilled nursing facility that all of the therapy that is delivered there is third party.
Yeah.
It's 100% third party. I was mind boggled to see that, because I was like, A, wouldn't it be cheaper if it was in-house? B, wouldn't it be more reliable? And the case is that it's not. And it's this therapy group that is basically, is full-time. If you're a resident, they look like they're just full-time. They're there 365 days a year. There's no days off. Every day is happening, Christmas, New Year's, whatever. Mm-hmm. And that was one of the reasons they cited, is because it is more reliable in terms of staffing, in terms of making sure, people are there. It does add some burden in terms of documentation and cross-documentation and billing. But it was really interesting like that. And then the other thing, again, like a sub challenge there that I'm sure you've seen, but just to share it with other folks, is that sometimes it's difficult to know the schedules when it's two different entities happening in the same area. And so, say some provider group, let's say it's a physician group, is rounding. They may not know who needs to be seen at what cadence based on, the care that they've received before. And those staff scheduling softwares don't really talk to each other, or it isn't, easy to share that kind of PHI over. And that can just add some headache. So it was a really interesting dynamic I saw, and I was very surprised that it was 100%, outsourced therapy.
Did you, outside therapy, out of curiosity, so like oftentimes like once a week, sometimes it's actually specialist groups, but there's oftentimes primary care groups that are coming and rounding to just provide primary care, because it's really hard for folks who are immobile to make it to an outside primary care doctor. You have to align transportation, get all those things aligned. Did you see any of those folks inside the facility during your time there?
Yeah, definitely. Yeah, there were. It was kind of nice that the scheduler really tried to get more specialists in than like transportation out, and that's a testament to them. I think it's also a testament to, it can be scary once your resident leaves the doors and you don't know what's happening, and you're pretty much on the hook unless you're quote unquote discharging for the day. And so that is something that they try to do. They also had groups that, I don't know, this is sort of where my expertise leaves, but they had groups that would bill on codes outside of what they can do in their bundled payments that would come in. And so that's like podiatry or dentistry, things like
all the
that.
ancillary stuff.
Right, exactly. And so they would come in, and that was really neat to see. I think that's a very interesting business model. What's also interesting there for, folks that are thinking about families is that the families might not know exactly how all that payment model works.
Yeah.
And so there's an interesting sit down when someone is getting, onboarding, doing all this contract work, to say like, do you want these services for your loved one? And, it's up to that person to be like, okay, you are eligible because you're like, it would be quote unquote, like free for you because of either Medicare or Medicaid. But like for some people, they might not know that it could be an out of pocket charge. And so that's, interesting dynamic, and it's up to the person who's onboarding to help spell that out for them.
Yeah, it gets even more complicated because then there's some cost sharing for certain codes. So if like you do like some of the like APCM stuff or any of the newer codes, some of that has cost sharing in it depending on the situation. And so like traditional rounding and just normal visits, fee for service kind of model are not, because they're just charged to Medicare. But then, and it's Part B, not Part A, right? So it's a different model. But then if they enroll them because they have a chronic illness in some sort of specialized program, then all of a sudden there's cost sharing. And then you have questions of, is the person have dementia? Or are they actually able to make the determination for themselves? It gets into some pretty sticky.
Yes.
Anyway, super interesting. Thank you for sharing, Ben.
Thank you. I see just a couple more questions, if that's okay, Paulius.
Yeah, we're good to go. Yeah.
How tech savvy were the folks at their homes? They're meaning the older adults that are residents at senior living or assisted living.
Yeah, you talked about printers as one idea, but just curious, like I've heard mixed things about certain populations are savvy. Obviously, it depends on the individual.
I have a lot of experience because I try to help people with their phones at my local senior center, outside of doing karaoke or hanging out. People are not tech savvy, and this is a challenge. It's a challenge because people are frustrated. It's a challenge because people don't know how to ask for help or I'll tell you a story about that in a second. And it's also a challenge medically. The two stories that I'll tell you is one, when I was at the senior living, someone told me that they wanted to get like Facebook on their new computer, XYZ. They reached out to one of these services that helps older adults with software. That person presumably helped them get Facebook on their computer. The older adult didn't know how to access Facebook. So it wasn't like it was there or not there. And so then there was this dispute over whether the service was, whether they helped them. And so this older adult didn't want to pay for this, software company that helped them get Facebook on their computer because they, weren't matched. And there's a lot of challenges there. And I think like if more younger generations or more tech savvy generations can just, volunteer and help out with people getting their computers and phones fixed, it'll be a better world. Also, if anyone just works for these platform companies like Apple, like if you can just make a different operating system for older adults, that would be beautiful. And that leads into my second anecdote about this is I think one of the most important times that I helped someone with their phone was at the senior center. They needed to log into their MyChart to their, their own EHR. And they couldn't figure out two-factor authentication. They were just so confused by it. They'd never heard about it. They don't know why they have this other code. They don't know where that other code goes. I helped them get on. I tried to explain as much about it so that they could remember it. But they were so happy at the end because they said, I would not have known to go to this appointment tomorrow unless I got in. And it's just like, it's a stress on the organization if there's no shows because people can't get into their EHRs. But it's also so sad that, like these privacy things are great, but they're barriers for people to understand and have health literacy or to understand and navigate their own health. And so I think it's really a challenge for this population. And then,
there's one more question from Rick.
Yeah. What are some barriers towards internal staff identifying and co-developing solutions towards issues you highlighted aside from turnover? So, I see. So this is about like when staff identifies an issue and they want, I see. Go ahead.
Thank you for sharing your story. It's amazing. And I think it's a great example of immersing yourself in the problem. And my mother worked in a nursing home for about 25 years, and I often hear about these problems. So my mind shifted towards two things. Like, does the revenue actually allow for a solution of these problems? And also, when we look at indicators of how a market is moving, people doing the job, people who are highly adept at their job, they're often better than any dashboard. So my question was in that realm.
Yes, I totally agree with you. They are better than any dashboard. And I learned this acutely. It was just like so interesting to, see the chemistry between the nursing staff and to see how they just had this understanding of all the residents on the floor and just something that a dashboard couldn't do. And I see this at hospice too. There's different indicators about when people, predictions of mortality, but it's the hospice nurses who know it the most accurately. By and large, maybe some newer hospice nurses, not so much, but these experienced folks, they really know this stuff. I think that the folks know these problems exist, but it's up to groups like this to sort of bridge the gap because people don't understand that they can fix these problems or how to fix these problems. And so I think being on the ground is a way to empower folks to remember that they are in the driver's seat. And so that's helpful. I live in New York City. It's a hub for innovation. And so it feels like anything is possible. When you're in Ohio, it doesn't feel exactly the same way. And I think that's, also some of the mentality is like, okay, like hopefully someone will think of fixing this. To your other point about market dynamics is that, margins are so tight in nursing homes and assisted living. And so I think it is, again, like on the macro dynamic. Again, I'm not an expert here, but like, how CMS reimburses, really does show how much different margin there is for exploratory things. And again, like that's why ROI is so important because, someone needs to know the top or bottom line is moving in the right direction if they're going to take on something new, or they're just going to really put a lot of trust in the person that's delivering, and that takes a relationship to build. So hopefully that's helpful.
Thank you.
Yeah.
This is super great. I really appreciate you guys coming together,